Welcome, Dr. Heidi Nelson. Dr. Nelson is the Emeritus Chair of Surgery and of Colorectal Surgery at the Mayo Clinic and is now the full-time Director of Cancer Programs at the American College of Surgeons. Welcome, Heidi.
Thank you, Dr. Wexner. Appreciate the invitation, the opportunity to talk a little bit about the cancer programs of the American College of Surgeons.
Well, you're doing a spectacular job running those programs, Dr. Nelson. We appreciate all your inspirational leadership. Perhaps you could start by explaining to everyone what are the cancer programs of the college and who participates in them.
The cancer programs really consist of 6 programs, 3 of which are accreditation programs that go back almost 100 years. As of 2020, we'll have a 100-year-old Commission on Cancer program. The newer programs are the National Accreditation for Breast Cancer, and as you well know, is the leader of the National Accreditation Program for Rectal Cancer, the more specialty-oriented accreditation programs. So their role is to examine cancer centers of all types, COC predominantly hospitals, and approve them based on their compliance with standards and how they perform in that regard. Then there are 3 infrastructure programs, and the infrastructure programs really kind of, as I think about it, help support the whole enterprise of the cancer department, which is the National Cancer Database, which of course provides the data that really helps determine whether we're achieving goals of improving cancer care, be that through survival metrics, benchmarks, quality measures, or the like. So without data, it's hard to know where you are in cancer care quality. So that's a very important job there. It's 30 years old. AJCC, American Joint Committee on Cancer, has been around 60 years. And basically, they set the language for cancer so that everybody's familiar with T, N, and M. That's the way of thinking about cancer and staging it in a way that we can all relate the same information and compare populations and how we're doing. So it really creates the standards of cancer language. And lastly is the clinical research program. The clinical research program is involved with NCI cooperative groups like the Alliance that conduct clinical trials and generate new knowledge. So, you have to have like the river flowing into the lake, you got to have new input into the system, and the clinical research program is one aspect of generating new knowledge, doing various kinds of trials. The clinical research programs also generated the brand new synoptic operative reports and the operative standards manuals, which sort of help tell us what are the critical elements of cancer surgery and how should we pay specific attention to those elements of cancer surgery. So that's an example of a new aspect of care that we're working on developing. It's part of the new standards. So those are the 6 programs.
And who administers the programs and participates in the decision-making about these programs?
Right. We have roughly at any given time between 40 and 45 staff at the college that actually administrate the programs. Connie Burra is my administrative assistant, she administrates the programs. She works at the college, as do all the staff. Well known in the programs, been around the cancer programs for a very long time. And then there's somebody managing each of the programs, and then the staff who do the work. But I think it's important to recognize that we've never really done an estimate, we probably have well over 1,000 volunteers I know AJCC has a distribution list of 400 people who create the different chapters of the book. The same kinds of thing is for the committees. Each of the programs have committees, and they constitute hundreds of people usually in each program. So it's quite a large group of academic and clinical leadership and people who do the work of building a lot of the material that's used to help move cancer care along.
Although it's housed in the American College of Surgeons, the constituent groups who help manage are groups other than surgeons.
Oh, absolutely. I think one of the value of the cancer programs is even though it started off being, probably very surgery centric, because back 100 years ago, surgery was the mainstay for cancer care. So it kind of evolved naturally. But as all evolutionary processes, we've brought in other disciplines and other groups. So for example, the leader of the Commission on Cancer is Dr. Larry Shulman, and he is a medical oncologist. The current leader of the AJCC is Dr. Robert Brookland, and he is a radiation oncologist. The editor of AJCC is a pathologist, Dr. Kay Washington. And if you look at the constituency of NAPBC, the National Accreditation for Breast Program, National Accreditation Program for Breast Cancer, the group is very multidisciplinary. It's very rich with every sort of aspect of cancer care, all aspects, not just the doctors either, nurses, social work, and the like. So it's quite robust, and I think the National Accreditation Program for Rectal Cancer is moving in the same direction. Only been around for fewer years, but is building that multidisciplinary team approach.
So given that background, that framework, what are the educational resources that the Division of Cancer is offering people to help get through this pandemic?
Thank you. That's a very important aspect of what we're doing right now. We've heard from our programs that it's going to be very hard for them to be compliant with a lot of our standards, such as tumor boards. They couldn't meet, so they had to go virtual. Cancer committees, the same type of thing. And their focus is now on COVID and managing all patients in their hospitals, as well as cancer patients in their hospitals. The other impact is directly on cancer patients who don't want to come into the facility if they can help it, because it exposes them to COVID, and they're a vulnerable population. So I think we recognized back in early March, that we had to do something to help everybody get a little bit more of a framework around how to think about cancer care, so people weren't left alone to make difficult decisions about how to triage. So for example, we started a triage document, I think it was March 10th, and the triage document was designed to help say which patients really are most urgent if you're going from phase 1 of COVID, where you have good resources, you're well prepared, you don't have many patients, you can still do some surgery because it's safe for everybody and it's reasonable, and you can keep moving some patients through who need the care, to when you get to phase 3, the more extreme is where you're in the situation where you're overwhelmed with COVID patients, and you don't have ICU beds, ventilators, staff, protective gear, and all of that. So we created triage criteria for breast, colorectal, and thoracic, and we did it in, I think, under 72 hours, and drafted that, shared that amongst other societies, the big important societies that cover those diseases, and so that they would have the same sort of awareness of this triage material and give us input, and then we pushed that out as soon as possible, recognizing it's just a framework. It's not how you make the decisions necessarily. It's not as evidence-based as we would want, but of course, where would you get that evidence? But it's based on what we knew about what would happen if you delayed somebody who had cancer, and are there alternatives to the delay? What harm would come from the delay? So I think we really tried to create sort of categories of risk so that it gave some guidance. And then we stressed, know your resources, use tumor boards. The benefits of having the infrastructure of the cancer programs at your hospital, it's there to use. And when you have an emergency like we do now, you can rely on that because you already know who the players are. You know how to reach them. You can push a button basically and get everybody together. And because you know who they are, you don't have to start with trying to assemble a group. So it's a ready-made tool. And then once we put the triage criteria together and had it more or less shared pretty widely amongst national groups, we distributed that electronically. And then we had webinars. And the webinars were to really kind of stand it up in a real live sort of way and to address questions that we had maybe hadn't anticipated or hadn't really addressed. So I think the webinars are really helpful for the question answer, for us talking amongst ourselves. It's one thing to share things in a written document. It's another thing to really kind of make it feel like it's a living thing that you can relate to and think through yourself when you're making these difficult decisions, because nobody wants to put a cancer patient in harm's way because they are vulnerable to COVID, nor do you want to put them in harm's way of their cancer. So I think those webinars are helpful. And then we've had subsequent webinars as well, as you know, having hosted some of them, to really get at where we're at and how to help our programs get through this.
One of the things that you mentioned earlier when you're describing the 6 programs in the Division of Cancer are the research efforts. So now we have COVID-19, previously unseen or inexperienced pandemic by any of us, and it does clearly have an impact on cancer patients, even if in a best case scenario, it's only a delay with no change in outcome. But how are we going to measure that, and what kind of research efforts is the Division of Cancer undertaking relative to cancer patients in COVID-19?
Yeah, that's an excellent question. And I can tell you we're on it right now. We're working hard to design the methodologies behind understanding the impact. We know there will be impact on cancer patients. We know that the National Cancer Database generally has historically had calls for data every year, and that meant the data was older and wouldn't be as relevant. We'd have to wait a couple of years to get the answers. The new system, the Rapid Cancer Reporting System, RCRS, is going to be available in June. Our team's working very hard to test and validate that, and it should be coming online very soon in June. And in that way, registrars can put patient information into their registry real time. And we will probably want to look at quality measures, because we've heard that patients aren't necessarily getting their this typical care. Maybe they're getting, instead of getting long course radiation, they may get short course. They may be on hormonal therapy instead of going right to surgery. They may be getting more chemotherapy up front, or they may simply have a longer time to treatment. So we probably can look at some quality measures to see when are we back to some semblance of normal. That'll be the important first question. We can look at the various experiences with COVID. If you're in New York City versus you're in Minneapolis, it may be a very different experience, and the flattening of the curve may have implications versus the steepness of the curve, or it's the area under the curve. We don't know yet, but certainly there's so much data, rich data out there, that we're going to be able to look at the impact on cancer patients. And that'll be not only important for looking back at this experience, but we do know that, we have the flu every year. Are some of the things we're doing with COVID going to have implications going forward? I know some hospitals don't let any visitors in at all, which is draconian, inappropriate, unfortunately. Thankfully, there's probably virtual visits that people can do and feel, like they're close to their loved ones. But maybe, there's going to have to be some slightly different approaches to how hospitals manage high-risk patients, vulnerable patients, going forward. I mean, there could be some lessons learned from this pandemic that are really important. And we know from a study done by American Cancer Society that an experience with hurricanes did in fact decrease lung cancer survival. And so we know that this may have an impact on long-term outcomes, which we can't measure now, but maybe in 2 to 3 years we'll have some clues. But just looking at time to treatment and any number of other variables, we'll be able to see what kind of impact this had on cancer patients. And as you know, the Chinese experience shows that cancer patients were more vulnerable and more frequently had COVID than a normal population, probably because of the touch points with hospitals. And surgical patients did worse during COVID because they got COVID and then they got the complications and fatalities from COVID. So these are things that, some of which we can study, but hopefully other registries in the college can also study for things that we don't have the data on.
Well, thank you. Those are really important insights into both how we're dealing with the COVID-19 pandemic and the Division of Cancer, as well as to the Division of Cancer overall. So I thank you for your time. I wish you and your loved ones continued safety and health through the pandemic, and look forward to seeing you in person when all of this pandemic is behind us.
Yeah, thank you very much. I hope you keep well. And for all the folks listening, appreciate all your frontline efforts and stay well. Thank you, Steve.